to connect differently in the future. So I'm going to be speaking about management strategies of high-frequency ventilation in neonates, and I will let you know that I have no conflicts of interest to disclose, and I'm not making a lot of money off of this, so I just want you to know that I have no connections to commercial devices or anything like that. So this is just a pleasure for me to be here. So I'm going to start by talking a little bit about this picture here. So if we look back at the early days in the research that was done with the baboon studies, I had one of my mentors and my colleagues, Mr. Gordon Lassen, who was from Utah, where I'm originally from. He was a great mind in high-frequency oscillatory ventilation. And in the late 80s, he had the opportunity to travel to San Antonio and observe this study while it was in progress. And it was among one of the very early foundational studies that resulted in groundbreaking information about the use of high-frequency ventilation as lung protective strategies. So the facility had a fully staffed labor and delivery unit where they could C-section the baboons at a particular age. It was about 140 days, plus or minus 2, that would be very similar to a premature infant, human infant, with a surfactant deficient lung. So probably in that 26 to 28 week gestational age. And they also had a fully staffed ICU. So this is a picture that Gordon had taken while he was there. You can see that the baby baboon is attached to not only the ventilator with an endotracheal tube, but all of the other monitoring devices and IVs and things that you would expect to see in a NICU. So this study looked at 19 baboons, and as I mentioned, they were delivered prematurely, so they knew when conception happened, and by ultrasound they were able to deliver them relatively within plus or minus a few days of each other. They were half of them were placed on positive pressure ventilation with PEEP and with adjusted tidal volume and frequency to keep their PaCO2s less than 55. And the other half were placed on high frequency at 10 hertz with the same goal of that PaCO2 level. So the half that were placed on high frequency oscillation survived the entire 11-day experimental period without evidence of air leak, either pneumothorax or PIE. Of those that were placed on PPV, 6 of the 11 developed PIE or pneumothorax, and 5 of them died within 48 hours. So with these, mean airway pressure was higher initially in the high frequency group, but was lowered more rapidly than those subjects that were on the PPV and PEEP subject group. And then FiO2 was also weaned more rapidly with high frequency, and it was significant even within the first 20 hours. So following their 11-day study, they terminated the support of ventilation and humanely dispensed with the baboon, and then they were able to do lung tissue studies, which they were able to see more evenly distributed inflation of the lungs and so on. So that's just kind of a brief reminder. I'm sure many of you are very familiar with a number of these studies that occurred. And so we've come a very long way since this study and other studies that were similar, both in conventional ventilation and in high frequency ventilation. And through the research, both of those approaches have greatly improved. And so my objectives today really are to kind of narrow down a little bit. There's an enormous amount of information that's available that could take really an entire conference. In fact, in Utah, I believe it's every spring, they have the Snowbird High Frequency Conference, and it's a number of days, and it specifically focuses on high frequency ventilation. So I'm going to pare down what I'm going to discuss into the time frame that I have. So the goals today are really looking at what high frequency offers, a brief overview of the controls and the general recommendations in neonates, some of the initial settings, depending on your goals for the baby, and some monitoring and assessment. I have a few slides on disease-specific management strategies. As we know, not every baby is different, even though their pathologies are the same. So they're general guidelines. And these are also applicable to across devices. Devices that are used in one facility may not be available or used in another facility. So the principles are the guiding parts of what I'm going to discuss today. And then we'll talk a little bit about maybe some of the pitfalls and adverse effects that exist. So there are many devices that have been created that offer high-frequency ventilation, and there are also a number of types of high-frequency ventilation. So we have jet ventilation, oscillatory, high-frequency positive pressure ventilation, flow interrupter. There's a lot of different devices. They also vary with their technology. Some of them are created now to have conventional ventilation and high-frequency modes, which eliminates the need to remove a child from one and to place them on the other. Performance and function capabilities and limitations vary. Cost also varies. The versatility, and we'll talk about transport a little bit, and then really the user-friendliness of the device itself. So again, I'm going to talk more in general terms regarding the principles of active inspiration and expiratory phases and some of the applications that we can use when incorporating high-frequency ventilation. So when we look at specifically at high-frequency ventilation, the characteristics that exist, we have a range of frequency. So they're measured in hertz, and with high frequency, the range is considered 3 to 20 hertz, which will give you approximately 180 to 1200 cycles in a minute. There's active inspiratory and expiratory phases, which I have a chart to show you in a moment. The tidal volume is very minimal. It's not like a bulk convective flow of ventilation into and passively exhaled. It's active during inspiration and expiratory phases. And then the gas mixing efficiency, which is also very effective in this type of ventilation, and our ability to recruit and stabilize the lung and to not require the distending pressures necessary with conventional type of ventilation. So I'll be talking about control variables and some of the considerations that we might have when we determine whether or not we're going to put a baby on high frequency, if that's a good match. And I want to just kind of show this just as a reminder for us, so you can see the conventional breath, which is an active breath in, and then passive exhalation down to our baseline variable, which is our PEEP. In comparison to high frequency, where we're going to have a mean airway pressure that will be set, and then we have active push in and out with the diaphragm of the oscillator to create the peaks and troughs. The difference between there will be we have our amplitude that will be set, and then the frequency will be the number of ventilations. So this gives you a little bit closer up view of that same slide. So when we consider placing a baby on high frequency ventilation, there's things that we need to probably think about prior to making that decision. Is the patient currently failing conventional ventilation, or are they at maximum settings that causes great concern? Are the PIPs significantly higher than we're comfortable with? Is the mean airway pressure elevated? Are they on high amounts of PEEP that have caused those mean airway pressures to be elevated? And are we concerned with what those settings are and the potential of the barotrauma and volutrauma that might occur? We have to consider the support and treatment that is available with high frequency and the type of patients. So patients with RDS, PIE, air leaks, meconium aspiration, and a number of others may benefit from high frequency. One thing to consider also is the patient hemodynamically stable. So with the mean airway pressure, that's constant descending pressure, which is higher than the baseline PEEP that we use in conventional, we want to make sure that the patient is hemodynamically stable. If they're not, and the application of that mean airway pressure, that continuous descending pressure is applied, we may have hemodynamic challenges. So it's best to optimize hemodynamics prior to initiation. Another thing we would consider is sedation or sedation with neuromuscular blocking agents. Is that something that needs to be considered for that particular patient? Of course, a review of X-ray so we know what we have prior to implementing, and then our X-rays that follow afterward with blood gases that help us determine our goals. And then one kind of big thing to consider, and it really depends on the equipment that's available within the facility, is do you anticipate that the patient will have off-unit procedures that they need to travel for? So we know that disconnecting from ventilation from one piece of equipment to another is not optimal. And if you don't have the ability to transport with your oscillator, is it something you can do that procedure prior to, or are there other ways that you can facilitate transport? I know here at KU, the University of Kansas Hospital System, they have the 3100A, and they've equipped it with a battery pack and with the oxygen cylinders and air cylinders to be able to blend the gas appropriately and switch seamlessly from being plugged into the wall to generator to be able to transport without having to disconnect the baby. But that is definitely a retrofit to that particular device. It's not something that is kind of built into that device currently. So we look at the control variables, and I put primary considerations at the top because truly we have to consider the pathology of the lung disease and the patient birth weight in a number of these. And when we get down a little bit further, we'll talk about really more specific strategies for certain pathologies. So I think that's something we have to consider as our primary drive for what we set our patient on. With our mean airway pressure, the main goal is to impact oxygenation. We know that using FiO2 and using our mean airway pressure, that's going to allow us to optimize our PaO2 in our baby. So we want the least amount of oxygen and the least amount of descending pressure to be able to accomplish that. This will increase lung volume. It helps with increasing surface area. Will generally, and you know, different information says different things, but generally speaking, expanded to the 8th to 9th rib with that mean airway pressure. If it's too low, we're going to experience atelectasis and loss of surface area. If it's too high, we have overdistension and potentially having cardiopulmonary compromise with hemodynamics. And then if we don't have our mean airway pressure stabilized, it's possible we may have an impact on our PaCO2. When we look at the amplitude, so the height of the peak and trough of the waveform, some will refer to it as delta P. We look at this as a direct impact on ventilation. So it doesn't have much impact on PaO2. If the mean airway pressure is too low, however, then amplitude may increase lung volume. And this really isn't the best. It's not the recommended way to approach ventilation. When you start seeing your amplitude of your wave reaching approximately 3 times your mean airway pressure, that's kind of a red flag and something to be concerned about. That maybe you need to consider increasing your mean airway pressure and recruiting better to have greater surface area for gas exchange, and you may not require the same amplitude in the settings. One thing also to kind of look at, we know that the pressure that is delivered by the ventilator and measured at the Y is not necessarily the pressure that is delivered to the terminal airways. So there's an attenuation of that wave due to it hits the ET tube and begins to become a smaller sine wave. This is determined also by the size of the endotracheal tube. So if it's a 2.5 ET tube, there's a greater attenuation. So 90% of that wave is lost before it reaches the alveolar space. If it's a larger ET tube, then less of that attenuation occurs and greater pressure is transferred to those alveolar spaces. We look at our frequency. Increase in frequency causes a decrease in tidal volume. It's counterintuitive to kind of what we would think. And we have an increase in CO2. So we'll see a decrease in tidal volume and an increase in CO2 with an increase in our frequency. So faster rates have the potential of greater air trapping because of the decreased amount of E-time. Because the hertz are, when they're decreased, increases our tidal volume, we also have to think about those distal airway pressures. So I have on the next slide, I'll kind of show you what I'm talking about regarding that. The range really that we would pick for our neonatal population will be between 10 to 15 hertz for preterms and up to our near-term infants. And those are likely determined by the pathology that we're treating. And it really, okay, I already said that one. So for IE ratio, most applications will use a 33% I time or a 1:2 IE ratio. There are some studies and indications that say you can shift that IE ratio. I know here at KU, they're pretty firm on staying close to that 1:2 IE ratio. We need to keep in mind that if we increase, if we change the IE ratio, we may be increasing our tidal volume. For example, if we go from a 1:2 IE ratio to a 1:1, we have an increase in that tidal volume. If we go from a 1:3 to a 1:2, we also have an increase in tidal volume. In some cases where there's a presence of refractory hyperoxemia, at maximum settings, an increase in my time might be beneficial in helping to improve ventilation and recruitment. So let me show you this waveform here that kind of reflects the attenuation, and it also shows how frequency changes that attenuation as it's delivered. So if you look at the bottom one here on the left, you have a higher frequency, and the pressure, the amplitude here is higher. It's right close to that 35 mark here. But as that high frequency attenuates, you can see it has a much smaller sine wave at the airways. So a lower pressure is actually delivered at the airway. If you have a slower frequency, you have much larger volumes, and that also translates to greater pressure at the alveoli. So we need to kind of keep that in mind as we're making some of those adjustments. Bias flow is something that we're also going to set. This is patient size dependent, and really we need to select the lowest flow that is appropriate to allow us to meet our mean airway pressure. If we don't have sufficient flow, we're not going to be able to meet that mean airway pressure, but we don't want to have flow in excess of what's necessary to meet our mean airway pressure. So ranges of 10 to 15 for preterm babies, or 10 to 20 potentially for closer to term babies. And then I included the CO2 diffusion coefficient. This is not a controlled setting, although I have it under control variables. It's something that is available and is calculated on some of the newer ventilators. So I wanted to mention it here. It is a direct relationship of the effectiveness of CO2 removal. So, and generally speaking, if you have hertz that are 5 or above, you can approximate what that is by looking at the tidal volume squared times the frequency. And a rough target is around 40 to 80 milliliters squared divided by seconds for a 1,000-gram baby. So we want to keep in mind that if we increase tidal volume, we should also see an increase in DCO2. However, they don't increase at the same percentage. For example, if you increase your tidal volume by 10%, you would see a 21% increase in DCO2. If you increase by tidal volume by 20%, you would see a 44% increase in DCO2. So the DCO2 value will exponentially increase with those incremental increases in tidal volumes. So just so we can understand that value. So the next two slides are just kind of general initial settings. One is for optimal lung volume and one is for a low volume strategy. And then we'll look more at specific pathologies. So with this particular one in mind, the optimal lung volume, we're looking really to maximize alveolar recruitment. So maybe we have an atelectatic lung, maybe surfactant deficient lung. We want to do some recruitment. We're going to set the frequency according to the underlying pathology. Mature infants may start around 10 hertz. Preterms may range from 12 to 15 for initial settings. We will set the amplitude to achieve adequate chest movement. That should be between the chest and the umbilicus, that adequate chest movement, the vibration there. Mean airway pressure for this strategy would be 2 to 3 centimeters over whatever the mean airway pressure has been on conventional ventilation. And then you can increase it by 1 to 2 centimeters until you can achieve your optimal oxygenation. And then we also want to verify that mean airway pressure with chest x-ray to make sure that we haven't overdistended. If that's the case, we would adjust mean airway pressure down and potentially use slightly more FiO2 to achieve our desired PaO2. With a low volume strategy, we're really looking to minimize lung trauma. And this will kind of play into some of those other pathologies that I'll mention in a moment. We'll select a frequency again according to the pathology. We adjust the amplitude to determine our chest wall movement, and we're going to probably set our mean airway pressure equal to what's on the ventilator, conventional ventilator, versus the previous slide that said 1 to 2 higher. So this is a little bit different approach to minimize trauma. And then, of course, using FiO2 to achieve our appropriate PaO2. So a little bit more specific, if we look at management strategies for diffuse homogeneous lung diseases, so RDS, if we have diffuse pneumonia or bilateral hypoplasia, things like this where it's kind of uniform throughout, we would like to have uniform recruitment. We're going to optimize our lung volume and surface area is kind of our goal. And again, this falls under that lung recruitment one, that the volume that I mentioned earlier, to set our mean airway pressure at 1 to 2 greater than what we were on in conventional ventilation. Amplitude will have small chest movement. We want to minimize the risk of barotrauma and volutrauma. So we want to potentially use 10 hertz for mature infants and 12 to 15 for premature or low birth weights, and an IE ratio of 1 to 2. If you are placing a baby on high frequency ventilation prior to surfactant delivery, I have the next slide that shows a suggested algorithm for that lung recruitment and what you would do prior to and after the delivery of surfactant. But that's something that we need to consider when we're stabilizing the baby prior to the delivery of surfactant. And I'll share it with you really quick, but I want to pay attention to time. So if I have time, I'll come back to it, but I'm happy to share these slides with you. But this is one recommendation, starting at low mean airway pressures and higher FiO2s to get our saturation where we want. Then you stair step your mean airway pressure up as you reduce FiO2. You figure out where the stabilization is where you can no longer decrease FiO2, and then where your saturation fails with a drop in mean airway, you re-recruit and then stop 2 centimeters above what you achieved in 4. We apply the surfactant, and then we do another recruitment. So I'm not going to take a lot of time on this, but I wanted to share that. If we have non-homogenous lung disease, so meconium aspiration syndrome, unilateral hypoplasia, or BPD, we really want to avoid overdistending the lung areas that are compliant. We don't want to damage those. We know we have areas that are not doing well, and we want to make sure that we don't cause damage in other areas. So we need to oxygenate and ventilate effectively while we prevent new injury. We allow those areas to heal, and we want to have an amplitude that gives us visible chest movement. If air trapping is one of the concerns, such as in meconium aspiration syndrome, we may need to look at our mean airway pressure and ensure that it's sufficient to prevent collapse of the airway, so we don't have that air trapping distal to the obstruction. But also keeping in mind that, you know, we're doing this as a protective strategy as well. We may need to adapt to the disease process. If we think about meconium aspiration, it usually is an acute inflammation with a lot of secretions initially. As it develops, it changes slightly to something that's a little bit more consistent to like a chemical pneumonitis and patchy atelectasis. So at that point, we may consider recruitment strategies or other approaches to caring for that particular patient. With air leaks, we want to use a low mean airway pressure and reduce overdistension. The amplitude may be minimal, but it needs to be adequate for chest movement. There is some information in here regarding gross air leaks and pulmonary interstitial emphysema. So with gross air leaks, we will use low tidal volume amplitudes and higher frequencies. Mean airway pressure is 0 or 1 above conventional. In PIE, we will use mean airway pressures that are 1, probably less than our conventional. So we want to avoid aggressive recruitment techniques because, again, we don't want to complicate the leak syndrome that is currently happening. We may consider keeping our FiO2 slightly higher in order to keep our mean airway pressure lower. And if it's a unilateral, we want to make sure we monitor our healthy lung or our healthy areas for those overdistension. With PPHN, we want to consider the underlying cause for this. If it's primary PPHN, we need to optimize hemodynamics prior to initiating and treat that hypovolemia or hypotension. We want to be conservative with our mean airway pressure, that it doesn't overdistend the lung. We also want to make sure we don't underdistend. So we need to find where that happy medium is and make sure we're using our X-ray to determine that. Begin with your mean airway pressure that you're using on conventional ventilation, and if it's possible, monitor CVP to make sure that we have adequate circulation. Secondary PPHN, really looking for the underlying pathology and treating that, recruiting underlying atelectasis, and that may help improve the patient condition. With high frequency, we can use nitric oxide. So if that's something that's available for severe PPHN associated with RDS and meconium aspiration, that might be something to consider. With these patients, there is a lot we have to assess. So of course, we're going to chart all of the settings that the patient is on and the interface and how the patient is responding to that. We need to assess the chest wiggle. Do we see dampening? Do we feel like there's suctioning that needs to occur? Has the tube become dislodged? What is the reason for that? Blood gases and chest X-ray are going to be vital to our assessment. I'm going to be quick so I know where time is going. Heart rate and hemodynamics, the lung mechanics, making sure we're assessing breath sounds and ensuring that we have bilateral expansion. Blood pressure is an indication that we may have our mean airway pressures too high, and then assessing neurologic status to ensure that our patient is comfortable during this intervention. A few things to consider. Some babies just simply do not tolerate handling very well, and switching from ventilator to ventilator, so going from conventional to high frequency. If you do make the switch and the baby does not respond well within a reasonable amount of time, then consider switching back to conventional ventilation. And keeping in mind that lower lung compliant babies will require higher amplitudes to really get that same tidal volume that you would achieved with lower amplitudes in compliant lungs. So keeping that in mind and knowing that those airway pressures will translate to pressures at the alveolar level. A few pitfalls that we run into, if you anticipate that your patient's compliance should be improving, say for example, you've administered surfactant and you would anticipate that compliance should improve and oxygenation should improve, but you see desaturation, it's possible that your mean airway pressure is too high and you may want to consider decreasing the mean airway pressure. Disconnecting for suctioning is highly discouraged, ensuring that you have inline suction available. And then blood pressure, if we notice falling blood pressure, again, we want to refer back to our mean airway pressure and potentially supporting hemodynamics with fluid or inotropes. As with any intervention, there are negative effects that may occur with our efforts to save lives and positively use positive pressure to ventilate babies, whether it's conventional or high frequency. There are always complications that may occur or adverse effects. Hyperinflation, we mentioned, pneumothorax is possible. Secretions, making sure we can manage secretions, preventing hypotension with as much as we're able to with appropriate mean airway pressures, and then de-recruitment, any breaks in the circuit, as I mentioned. So really, in summary, high frequency is widely used alternative to conventional ventilation. It can be used for a variety of different disease processes, and it offers the ability to oxygenate and ventilate with a reduced risk of barotrauma and value trauma. However, we have to make sure that we understand the complexities of the patient pathology. We need to understand the lung mechanics, all of the variables that are part of the high-frequency ventilator, what are the lung protective strategies, and understanding all of those and being able to use them appropriately will provide us greater option for success. Inexperience, however, and lack of understanding are likely to not result in success and may actually be harmful to the patient. So no two patients are exactly the same, and even if they share the same pathology, we may need to approach them slightly differently. There are many modes and approaches to invasive ventilation and oxygenation for a neonate, and it's our responsibility to be well educated and well practiced on the options that are available. The use of the particular modes and how the variables impact the delivery of the support that we're using, and ultimately our interventions should be guided by evidence-based practices. So with that, I say thank you, and I'm going to close. Oh, I have my references on my next page too, so there you go. I will stop it. There we go. Thank you. Sorry, I tried to get that through that quickly. I probably spoke very fast.
Thank you. Thank you, Lisa. Dr. Soha? Soha, do you have a question?
Thank you. Thank you, Dr. Lisa, for your nice presentation. I have a question about the target ventilation, tidal volume ventilation with the high frequency. Do you have any experience with this mode?
With the volume targeted, I have not personally had experience with that on clinical patients. I have read about it. I'm in the classroom now, and so we work a lot with just the specifically high frequency ventilators. I know that it's a very good option to use. I wish I could give you a little bit more information regarding that, but if you can put your email in the chat, I would be happy to send you a little bit of information.
Okay. Professor Reggie.
Thank you so much.
Dr. Lisa, thank you for your presentation.
Yes, please.
Dr. Lisa, thank you for your presentation. I would like to ask you about posturing the baby while on high frequency ventilation. If the baby is having unequal pathology, he's having a unilateral pulmonary interstitial emphysema, for example, on the right side. What about ventilating him while putting the right side down in the right lateral position? I've seen it working several times to decrease the lung pathology when you and vice versa. If one lung is underinflated, put it up. When you put it up, you will help to expand it. And I would like to know your experience in with high frequency in congenital diaphragmatic hernia.
Okay, thank you. With the positioning, as you mentioned, taking the affected side, if it's atelectasis or that decreased lung volume and putting it up, we do that with many of our patients with lots of pathologies, whether they're even patients that are not in the ICU but have atelectasis on side. If we're doing any kind of lung recruitment techniques, so I feel like that is an appropriate approach to doing that affected side up. You mentioned with PIE putting the affected side down. Is that what you mentioned?
Yes.
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 Thank you. And so I think we have to be careful. The approach to putting the affected side down, so the ventilation is going to that healthier side. Of course, we want to reduce additional injury and additional leak if we have the leak on the one side. Positioning it down would push the ventilation toward the healthier side. I would say be careful with the overdistension of that healthy side or any additional increase in PIE that may be impacted by that.
And what about diaphragmatic hernia? Diaphragmatic
hernia. So with that one, that would fall under like the unhomogenous, or if you have like hypoplasia, a non-homogenous or a hypoplastic lung on one side, where, let me pull that slide really quick. One moment. So if you have that, I won't share it again, but I would say that would fall under the same with the unilateral hypoplasia, because that's what you would have if you had that diaphragmatic hernia on one side. So we really want to make sure that, again, we don't overdistend the compliant lung. We don't want to cause damage to the one that is working, that is healthy. We need to allow, prevent any kind of gas trapping, but using low volumes that are able to give us the ventilation that we need, reach the CO2s that we need, making sure our mean airway pressures are not such that they cause damage to the lung that is healthy.
Thank you.
Thank you.
Thank you, Lisa, so much. Dr. Khaled, you want to have a question?
Yes, please. Thank you, Lisa, for this very nice, elaborative presentation. Now with the trend going towards the non-invasive ventilation, what's the experience with the non-invasive high-frequency ventilation?
So I have, again, this is one that I have read about. I know that it's a relatively new option for ventilating. I don't know that I can, in this forum, speak intelligently on research-based kind of information regarding that, but I know that it is used. It's used in our children's hospital here, and so I'm sorry, I can't give you a very good answer that I could. It would be anecdotal.
Thank you very much.
Now, Dr. Khaled, President of Arab Neonatal Care Group, consultant neonatologist at Latifa Hospital, Dubai, United Arab Emirates, will present Dr. Prof, please.
First of all, let me thank Professor Shamawad, my dearest professor and my godfather in the